Hello everyone, welcome to RAAONLINE. So today we are going to learn how to approach a patient with liver disease, and we'll start off with symptoms and signs. So before we delve straight into the symptoms and signs, let's understand three different patterns of liver diseases. One, they can be hepatocellular. Two, they can be cholestatic. Or three, sometimes certain liver diseases can have a combination of both these abnormalities. So what are hepatocellular abnormalities? So in a patient with a hepatocellular injury, there is going to be a predominant hepatocyte necrosis, liver cell damage, and such diseases include viral hepatitis and alcoholic hepatitis. Now, cholestatic injury primarily refers to some kind of cholestasis secondary to a biliary obstruction. So, this is typically seen with gallbladder stones, other causes of biliary tract obstruction like strictures and malignancy, and primary biliary cirrhosis. And then finally, we have mixed pattern, certain diseases which present with both hepatocellular and cholestatic abnormalities, and such diseases include drugs and viral hepatitis. Now let's look at the symptoms of a patient with liver disease. Fatigue is surprisingly and interestingly the most common symptom that's reported by a patient with an underlying liver disease. And this fatigue is interestingly an afternoon fatigue, which means the patient is actually well once he gets up, and as the day passes by, the fatigue develops. Then patients may have itching. Now, itching is characteristic of patients with cholestatic diseases. So, pruritus is usually seen in patients with obstructive jaundice or with direct hyperbilirubinemia. Some patients can have a right upper quadrant pain. Now, this is often because of stretching of this glycans capsule around the liver. Now, right upper quadrant pain can be seen in patients with a gallbladder disease, liver abscess, sinusoidal obstruction syndrome, which was earlier referred to as the veno-occlusive disease, and in patients with acute hepatitis. So remember, whenever the patient has a right upper quadrant pain with a liver disease, these are the four differentials that will need to come to your mind. So either a gallbladder disease or an acute hepatitis or a liver abscess or a veno-occlusive disease. Now, gastrointestinal bleeding may be the presenting feature in patients with liver diseases. So in such instances, consider either esophageal varices secondary to chronic liver disease, or it could be a Mallory-Weiss stare following a forceful vomiting, forceful retching, as is seen in a lot of patients with frequent alcohol consumption. Then nausea is again a symptom of severe liver disease. Diarrhea can be seen in severe jaundice because of bile acid malabsorption, and jaundice itself is an important symptom which localizes the syndrome to the liver. And so I will be discussing jaundice separately towards the end of this session. Now, what is the relevant history that we need to ask in a patient with a liver disease? So when it comes to history of alcohol consumption, we have the famous CAGE questionnaire. What is CAGE? C starts with, do you feel that you should cut down on alcohol consumption? A, do you feel annoyed when persons inquire about your alcohol consumption pattern? G, do you feel guilty about your drinking behavior? And E, is it an eye opener? Do you drink the first thing in the morning? So, particularly with respect to alcohol, these are the four questions which will point towards the alcohol being a problem in the patient, the alcohol consumption being in a problematic pattern in the patient. So, CAGE questionnaire stands for C for cut down, A for annoyed or angry, G for guilty, and E for eye opener. So, if the answer to these questions is positive, that means alcohol consumption is a problem in this patient. So, then we have history of blood transfusion. This is basically because transfusion increases the risk of chronic viral infections of the liver like hepatitis B and hepatitis C. Whether patients are on oral contraceptive pills, whether patients are on drugs, they are all important causes of drug-induced liver injury. Now, family history is important when it comes to certain familial diseases, certain diseases with a genetic predisposition like alpha-1 antitrypsin deficiency, other diseases like progressive familial intrahepatic cholestasis or benign recurrent intrahepatic cholestasis. Herbal medicines again very important. They could be an important cause of a drug-induced or a toxin-induced liver injury. patients with intravenous drug abuse or recent trauma or recent surgeries, you have to keep it in mind that this becomes a high risk factor when we consider them to be at risk for chronic hepatitis infections like hepatitis B and C. Travel history, again something that is important, and then finally sexual history. Now, what are the signs of a patient with chronic liver disease? In the eye, from head to foot as we go, we have icterus. Now, icterus is commonly observed in the bulbar conjunctiva over the sclera, and icterus is usually clinically significant when the total bilirubin levels increase beyond 3 mg per deciliter. That's when you're able to appreciate the scleral icterus. Even before the sclera becomes yellowish, in a patient with jaundice, the patient starts developing darkening of his urine color. Then in the eye, another important thing that we need to look for, the first thing is icterus, the second thing is the Kesha-Fleischer's ring. This is a ring that is seen in the Descemet's membrane, which is helpful in diagnosing a patient with Wilson's disease. In the head and neck region, you will have to look for parotid enlargement, which is a frequently encountered sign in patients with chronic alcohol consumption. Fetor hepaticus, where the patients have a strange ammoniacal odor emanating from the mouth, which tells you that the patient has features of advanced chronic liver disease. In the trunk, what is significant are the spider angiomata. They are basically dilated capillaries which are actually seen in the trunk. They are visible in the face, neck and the trunk. They can also be seen in other vasodilated states like pregnancy. Easy bruisability because of the coagulopathy can be seen. Gynecomastia is an important feature in patients with chronic liver disease, and hyperpigmentation. So, hyperpigmentation can be seen in patients with hemochromatosis. In a patient with chronic liver disease, palmar erythema is something that is commonly seen. Dupuytren's contracture is seen in patients with chronic alcohol-related liver disease, and when patients have asterixis or flapping tremors, then we know that the patient is in hepatic encephalopathy. So, these are the things which we look for in examination. And finally, once we complete general examination, coming to the abdomen, patients can have ascites, which could indicate that the patient has a chronic liver disease. In long-standing ascites, patients tend to have striae, umbilical hernia. Patients can even have dilated veins. Patients can have features of portal hypertension in the form of caput medusae, which are portosystemic shunts, dilated blood vessels around the umbilicus seen over the anterior abdominal wall. Patients can have hepatomegaly. So, chronic liver disease with an enlarged liver, what are the differentials that you will think of? You will think of a sinusoidal obstruction syndrome or a veno-occlusive disease. Infiltrative diseases like amyloidosis and malignancy, and alcohol-related liver disease. And you look for splenomegaly also. Splenomegaly is an important feature in portal hypertension secondary to chronic liver disease. And finally, on examination of the genitalia, testicular atrophy will also be seen in patients with chronic liver disease. And finally, moving down to the foot, you find that patients with chronic liver disease develop pedal edema, which could be attributed both to hypoalbuminemia and a functional IVC obstruction from all the ascites that is there. So, this is a picture of palmar erythema that is seen in patients with chronic liver disease. The picture below, that is how a classical spider nevi looks like, or a spider angiomata. Now, this is usually found in areas of SVC drainage. That is the reason why it is found in the upper half of the trunk, head and neck. And they are not only seen in patients with chronic liver disease, they can also be seen in patients who are pregnant and in patients with oral contraceptive use. So, this is how a typical spider nevus looks like, but it is very difficult to pick it up in dark-skinned individuals. Now, this picture shows dilated vessels around the superficial dilated veins around the umbilicus, as you are able to see here. You are able to see as though they are all radiating from the umbilicus. Now, medusa, this is caput medusa. Caput medusa is basically head of Medusa. So, Medusa was a demoness who had hair looking all wavy like this. That is why this is called caput medusa. This is one of the portosystemic shunts which portosystemic collaterals which open up in patients with portal hypertension secondary to chronic liver disease. Now here you are able to see ascites. From one look you can tell that this patient probably has a long-standing ascites, 1 because of this striate, 2 because of this umbilical hernia. Usually the umbilicus is inverted, but here the umbilicus is everted. That tells us that this patient probably has a long-standing ascites. So these are all the various clues towards a patient with chronic liver disease. And this typically shows you how a KF ring looks like. Now KF ring is seen in patients with Wilson's disease, but this is better observed on the slit lamp examination, not very well seen on naked eye examination of the eye. So what are the different diagnostic tools that we use in when we understand liver diseases? So on one end we have imaging in the form of ultrasound, CT, which give us a lot of information about the liver and the biliary tract. Particularly if there is a suspicion of a biliary tract obstruction, then MRCP and ERCP are going to be very helpful in telling us whether there is an extrahepatic cholestasis or not. Now, what are the advantages of MRCP? MRCP is slightly better when it comes to common bile duct stone or the common bile duct obstruction from other causes like either a stricture or a malignancy, and in looking at congenital biliary diseases. Whereas when you take ERCP, it is better suited for ampullary lesions and particularly in patients with primary sclerosing cholangitis. So remember, MRCP seems to be slightly better than ERCP when it comes to the common bile duct obstruction, either in the form of a stone, stricture or malignancy. When it comes to ERCP, the prime advantage seems to be with ampullary lesions and in primary sclerosing cholangitis. Now, biopsy is extremely important both for grading and staging. We learn about the biopsy techniques and the various tools for grading and staging when we read about patients with chronic hepatitis and chronic liver disease in detail. Now, having said that, I'm going to jump into what is going to be the focus of this session, which is an approach to liver function tests. Now, as clinicians and as students, it is very important to be able to interpret the abnormalities in the liver function test. Now, liver function tests are often done as a part of a master health checkup in most communities, in most healthcare and pre-employment setups, and therefore abnormalities in liver function tests can be incidentally picked up. In certain other instances, a liver function test is asked for whenever the patient has certain problems. Like for instance, we could ask for a liver function test in a patient with fever. We could ask for a liver function test in a patient who has been on drugs with a right upper quadrant pain. We could ask for a liver function test in a patient with a known gallbladder or a biliary obstruction. So in such instances, when we do have abnormalities of liver function tests, how do we go about interpreting them? Now, this is very important even before we delve into the imaging tools and the grading and the severity indicators, which will all be discussed in details when we are discussing specific liver diseases, particularly the chronic hepatitis. So today, let's start out by understanding the liver enzymes, which is, there are 3 important liver enzymes. I'm going to be discussing the approach to liver enzymes separately and the approach to bilirubin separately. So, the 3 liver enzymes include the transaminases, which is the AST or the SGOT, and ALT or the SGPT, and then finally we have the alkaline phosphatase. Okay, so this AST is the aspartate transaminase and ALT is the alanine transaminase. So generally I tend to get confused between which is SGOT and which is SGPT or vice versa. So what I do is I write ALT and AST in the alphabetical order. So L comes before S and the next one is not going to be in the alphabetical order. So O comes before P, so that goes down. Sorry, this is SGOT and this is SGPT. So ALT is your SGPT and AST is your SGOT, and then you have your alkaline phosphatase. Now, ALT and AST together are known as the transaminases. So, whenever a patient has liver abnormality, then we do liver function tests to look at three important things. One, to look for markers of hepatocellular injury. Two, to look for markers of cholestasis. And then three, we want to assess the synthetic functions of the liver. So how do we go about them? What are the markers of hepatocellular injury? Now these transaminases that I was just talking about, both AST and ALT, are the markers of hepatocellular injury. So two important markers of hepatocellular injury. One is the AST aspartate transaminase or the SGOT, and the other is the SGPT or the alanine transaminase, the ALT. Now the AST or the SGOT is going to be produced not only by the liver but also by the muscle, both the cardiac muscle and the skeletal muscle, by the kidneys, brain, pancreas, lungs, WBCs and RBCs in the decreasing order in which I just mentioned. Therefore, an elevation in the SGOT is not very specific to the liver, whereas when you look at ALT, alanine transaminase, you are able to see that this is largely produced in the liver and hence is more specific for a liver injury. So, between both SGOT and SGPT are markers of hepatocellular injury, but because SGPT is produced predominantly by the liver, this is slightly more specific than SGOT for hepatocellular injury. Now, the normal range of both SGOT and SGPT is somewhere between 10 to 40 international units per liter, and whenever patients have these transaminases in thousands, when the value is above 1000 international unit per liter, that means we are thinking of one of these three problems. It could be a viral hepatitis, could be an ischemic hepatitis, which is seen in patients with profound shock or prolonged hypotension, and finally it could be a toxin-induced hepatitis like in paracetamol or acetaminophen toxicity. So how I remember causes for massive transaminitis is VIT. So V for viral, I for ischemia and T for toxins. Next, let's look at the markers of cholestatic injury. Now, if AST and ALT reflect hepatocellular injury, then obviously your alkaline phosphatase should reflect cholestasis. So, in addition to alkaline phosphatase, there are two other important markers for cholestasis, which is 5-nucleotidase and gamma-glutamyl transaminase, GGT. Now, between these three, GGT is less specific for cholestasis, but it is also useful in picking up occult alcohol use. Now remember that alkaline phosphatase, just like SGOT, is not produced by the liver alone. There are other sources of alkaline phosphatase like the bone, placenta and small intestine to a certain extent. So this is not very specific for cholestasis. So remember that. Then we come to tests of synthetic function of the liver. So here we look at the albumin and globulin level. Now, albumin is a very good marker of the synthetic function of the liver. But the problem is that it has an extremely slow turnover. The half-life of albumin is about 18 to 20 days. So, although it is exclusively produced by the hepatocytes, because of the slow turnover, it's not a very great marker in picking up an acute decline in the synthetic function of the liver. So, a patient with an albumin level of less than 3 gram per deciliter points towards chronic liver disease, provided we've ruled out a protein leak from the kidney and from the gut, and provided we've ruled out a chronic disease like tuberculosis. Because in these chronic diseases, what happens? A lot of cytokines are persistently high, and these cytokines inhibit synthesis of albumin by the liver. That is why. And then you have globulin. Now, globulin is made up of three components: alpha, beta and gamma globulins. Now, alpha and beta are predominantly made by the hepatocytes, whereas gamma globulin is made up by B lymphocytes. So, any increase in the gamma fraction of the globulin tells you that alpha and beta fractions are lower, because that is directly synthesized by the hepatocytes. This is why in patients with chronic liver disease, the gamma fraction goes up. In addition, certain specific attributes of this gamma fraction of the globulin, their abnormalities can be used to pick up the kind of liver disease that we are dealing with. For instance, if there is a polyclonal increase in the gamma globulin, that may be seen in autoimmune hepatitis. If there is an isolated increase in IgM alone, that can be seen in patients with primary biliary cirrhosis. And finally, if there is an isolated increase in IgA alone, that can be seen in patients with alcohol-related liver disease. So, A for A, and primary biliary cirrhosis, the antibody is anti-mitochondrial antibody, right? So, therefore, IgM, M for M. That's how I remember. And then the first test to look at the synthetic function of the liver is albumin and globulin. The second test is by doing a prothrombin time with an INR, with an internationalized normalized ratio. Now, this prothrombin time with an international normalized ratio tells you how the clotting factors are. So, as far as the clotting factors are concerned, almost all the clotting factors except for 8 is produced by the liver, but remember that 2, 5, 7 and 10 are dependent on vitamin K. Therefore, reduction in these clotting factors can be seen both in a liver disease or in patients with vitamin K deficiency, which can arise in patients with fat malabsorption, as it is a fat soluble vitamin. The advantage of clotting factors over albumin, the advantage of prothrombin time over albumin is that these have a rapid turnover and hence they are a better marker for predicting an acute decline in hepatic synthetic function. So, when we look at synthetic function, you have on one hand albumin and globulin. Your albumin is going to be low. Your alpha and beta fractions of globulin is going to be low, but because your beta cell is going to continue to produce your gamma globulin, that will be high in a patient with chronic liver disease. And in patients with an acute hepatic dysfunction, more than relying on albumin, which has a very slow turnover, we can do a PT with INR, which will tell us if the synthesis of clotting factors is adequate or not. An elevation in the PT with INR tells us that there is a deficiency in the synthetic functions of the liver. Another important test is looking at the serum ammonia level. Now, serum ammonia level looks at another important function of the liver, which is detoxification. Now, liver is involved in detoxifying ammonia. It converts ammonia into urea, which is then excreted by the kidney. Therefore, if the liver is not functioning well, then serum ammonia level is going to go up, and this is elevated in patients with hepatic encephalopathy, patients with severe portal hypertension, and this is a bad prognostic marker. It is a poor prognostic marker in patients with fulminant hepatic liver failure. So, remember, whenever you are looking at liver function tests, there is a reason why we look at them. Each one is abnormal in different scenarios. So, if there is a predominant elevation in the AST, ALT, you are thinking of a hepatocellular injury. There is a predominant elevation in alkaline phosphatase, you are thinking of cholestasis. So, because the alkaline phosphatase could be produced by also the bone, placenta and the small bowel, this can be supported by an elevation in the GGT also. Similarly, as SGOT is produced by a lot of other sites like the muscle, kidney and brain, we can rely on the SGPT more than the SGOT to tell us whether there is a hepatocellular injury or not. And then finally, when you look at the synthetic function, two important tests, the albumin and globulin, where the albumin is going to be low and the gamma globulin is going to be high, and a PT with INR, where if there is an elevation in the PT with INR, that tells us that there is an acute decline in the synthetic function of the liver. And finally, you have serum ammonia, which tells you that the liver is not detoxifying as well. Now, if the first thing that we need to do whenever we find an abnormality in the liver function test is to just simply repeat the abnormal test. The outlier needs to be repeated. So, if there is one parameter which is going to be abnormal, generally before that I need to tell you, when I refer to a liver function test, in most hospitals a gamut of tests are done. So, what are they? A liver function test generally measures the total bilirubin and it gives fractions of the direct and the indirect bilirubin. Then it looks at the 3 liver enzymes which I just spoke about. So, it looks at SGPT, it looks at SGOT and it looks like alkaline phosphatase. Then it measures the total protein with fractions of albumin and globulin. So, whenever you ask for a liver function test, most laboratories give you all of these tests. It gives you bilirubin, it gives you the 3 liver enzymes and it gives you the albumin globulin ratio. So, the first thing to do is when any one particular test is abnormal but all the other tests are normal in this battery of tests, the first thing that we need to do is to just simply repeat the test with the abnormal value. And then if it is still elevated, Then you look at the pattern of elevation. So is there a predominant elevation in transaminases, or is there a predominant elevation in the alkaline phosphatase? Now I already told you, if there is a predominant elevation in the transaminases, that is going to point towards a hepatocellular injury. And if there is a predominant elevation in the alkaline phosphatase, that is going to point towards a cholestatic injury. So sometimes patients can have both transaminases and alkaline phosphatase being elevated. In that case, we refer to it as a mixed pattern. So this is what we saw earlier, right? Patients can either have a hepatocellular injury, or they can have a cholestatic injury, or they can present in a mixed manner with both abnormalities. So looking at the liver function test, particularly at the enzymes, will tell you what kind of injury the patient has, whether it is hepatocellular, cholestatic, or mixed. Now this is where the R ratio becomes very useful. So the R ratio, if it is more than 5, goes in favor of hepatocellular injury. If it is going to be less than 2, it is going to go in favor of cholestatic injury. And if it is going to be between 2 to 5, then you are looking at a mixed abnormality with both hepatocellular and a cholestatic problem going on. So what is the R ratio? R ratio is basically degree of elevation in the SGPT or in the ALT divided by degree of elevation in the alkaline phosphatase. So basically it is the ratio of your patient's SGPT divided by the upper limit of normal of the SGPT, and it is the ratio of the degree of elevation in SGPT versus alkaline phosphatase. So how high is the SGPT compared to the upper limit of normal versus how high is the alkaline phosphatase compared to the upper limit of normal. So if this ratio is high, that tells you that the SGPT is higher, the degree of elevation in SGPT is much more. So this tells you there is a predominant elevation in the transaminases, and hence the ratio is high, and hence the patient has hepatocellular injury. Whereas if the ratio is low, then there is a predominant alkaline phosphatase elevation, and therefore there is a cholestatic injury. So this is the R ratio. R ratio is ALT by upper limit of normal divided by ALP by upper limit of normal. And if the R ratio is between 2 to 5, it is mixed, more than 5 hepatocellular, less than 5 cholestatic injury. Now, if the patient has a predominant elevation in the transaminases, even by looking at the degree of elevation, we can classify the level of hepatocellular injury. For instance, if the elevation in transaminases is going to be less than 2 times the upper limit of normal, then we would call it a borderline elevation or a borderline transaminases. When the patient has the ALT and AST which is about 2 to 5 times the upper limit of normal, then we refer to it as a mild transaminitis. When the transaminases are 5 to 15 times the upper limit of normal, it is a moderate transaminitis. If it is more than 15 times the upper limit of normal, so just for you to have an idea, the upper limit of normal we just saw was 40 units per liter, right? So 15 into 40 is going to be 600. So if it is more than 600 units per liter, then it is a severe transaminitis, and values which are going to be more than 10,000 units per liter, often seen in toxin-induced or ischemic hepatitis or rarely in viral hepatitis, this is referred to as massive transaminitis. So based on the extent of transaminitis, we can classify the severity of the liver injury. So with less than 2 times the upper limit of normal being a borderline transaminitis, 2 to 5 times the upper limit of normal is mild, 5 to 15 is moderate, more than 15 is severe, and more than 10,000 is massive transaminitis. Now let us look a little bit more into how else we can interpret a patient with transaminitis. So playing on the same things that I said, so we just saw that the severity of transaminitis could be predicted based on the extent of elevation of these transaminases. Similarly, different liver diseases can be categorized based on the amount of transaminitis that is there. based on the amount of transaminase elevation. So for instance, as we saw earlier, when patients have transaminitis but which is less than 5 times the upper limit of normal. So upper limit of normal, as I said earlier, is about 40. Therefore, less than 5 times the upper limit of normal is going to be less than 200 international units per liter. So most often the diseases which will fall into this category include chronic hepatitis B and C, drug-induced liver injury, Wilson's disease, hemochromatosis, alpha-1 antitrypsin deficiency and autoimmune hepatitis. All of these are not very common. So initially, whenever you have a patient with transaminitis with the level of transaminases less than 200 international units per liter, think about chronic hepatitis, hepatitis B and C. Think about drug-induced liver injury. Therefore, look at the drugs which have been prescribed, see if there could be any incriminating drugs. And if you rule them out, then think about these rarer causes which includes Wilson's, autoimmune hepatitis, alpha-1 antitrypsin deficiency and hemochromatosis. Now, if the values are going to be 5 to 15 times the upper limit of normal. So, if it is going to be 200 to 600 international units per liter, then you will think of all of the above causes plus an acute hepatitis A, B and C. So, whenever the values are between 200 to 600, acute viral hepatitis becomes an important cause. In addition, you will be thinking of chronic hepatitis, chronic viral hepatitis, drugs and the other uncommon causes. Whenever you have your transaminases more than 15 times the upper limit of normal, as I mentioned earlier. So, when this is going to be more than 600 international units, then automatically you will think of either ischemia or toxin. Commonly, these two also could be seen in acute viral hepatitis. So, C is acute viral hepatitis and this is your VIT. So, when a patient has predominant elevation in alkaline phosphatase, as I mentioned earlier, the first test that we need to do would be the GGT, because that will tell us whether this is a liver origin or not. If GGT is elevated, then the second thing that you will do is to do a ultrasound, image the liver and the biliary tract to see whether there is any biliary obstruction. Now, if GGT is high and if your ultrasound shows biliary dilatation, then that tells you this patient has an extrahepatic cholestasis, right? Because there is a biliary dilatation, it could be a stricture, it could be malignancy, it could be a stone. So, this patient has extrahepatic cholestasis. Suppose the ultrasound is normal, then you're looking at causes for intrahepatic cholestasis. Therefore, you will have to look for drugs. Drugs is again an important, often overlooked cause of intrahepatic cholestasis. If you've ruled out drugs, then you will look at other rarer causes like primary biliary cirrhosis and primary sclerosing cholangitis. Now, in primary biliary sclerosis, anti-mitochondrial antibodies will be positive. In patients with primary sclerosing cholangitis, this occurs as a part of the IgG4 disorder. Therefore, IgG4 levels are often elevated.